Hello, I am Dr. Balasubramanian Tyagarajan. Today we are going to discuss an interesting and important topic called Quinsy. Actually, this term Quinsy finds its origin from the Greek word Quinsy. Greek word Quinsy it actually indicates in lay terms as dog throttled. Dog throttled. So let us, it is called dog throttle. It's actually a Greek term called dog throttle. Those days, hunting dogs were used for hunting, and they wanted the dog to be focused on the prey. So what they did was they prevented the unnecessary movement of the neck of the dog using a dog collar. So it's called as dog throttle. So similarly, the term Quinsy was coined to indicate the patients with this disorder who had difficulty in moving their neck. So that is the reason why this term Quinsy finds a place here. There are other names for this disorder also. So let us go to the synonyms. Peritonsillar abscess. Peritonsillar abscess is another synonym for Quinsy. So peritonsillar abscess, Quinsy also goes by another term called peritonsillar abscess. This is actually a accumulation of pus between the tonsillar capsule and the superior constrictor muscle of the neck. So let me repeat. By definition, Quinsy is accumulation of pus between superior constrictor muscle and the tonsillar capsule and the capsule of tonsil. So this is actually the definition of Quinsy, and this is commonly seen in adolescent males. Commonly seen in adolescent males, and it is unilateral. It is actually unilateral in occur. It is actually unilateral. Only one side is involved. And the probable etiology, they suspect obstruction to the crypts in the tonsil. So to be very frank, the medial surface of the tonsil is, I'll clear the board and we will discuss a little bit on the anatomy, which is going to help us in the better understanding. So the medial surface of the tonsil or the oral cavity surface of the tonsil has 15 to 30 crypts. These crypts are small pits, epithelial lined pits, lined by squamous epithelium in the tonsillar tissue, and these crypts are literally between 15 to 30 in number. They serve an important function of increasing the surface area of the tonsil. Surface area of the tonsil, because tonsil plays an important role in antigen sampling. So what happens, the presence of crypts increases the surface area of the tonsil literally 3 times. So the medial surface, I repeat again, medial surface of tonsil is lined by 15 to 30 crypts, and this crypts plays an important role in increasing the surface area of the tonsil. Crypts are nothing but small epithelium lined pits seen in the tonsillar tissue, and these pits are lined by squamous epithelium, and especially one particular crypt is slightly deeper than the others. It is known as crypta magna. This is actually a fairly deep crypt which extends throughout the extent of the tonsillar substance. It may even go up to the level of the capsule of the tonsil. So roughly speaking, assuming this is the crypta magna, this is the tonsillar tissue, this is actually the crypta magna. So these are the follicles. So this is how the crypta magna is going to look like. These are nothing but follicles. So this is the crypta magna. So what happens is, if this follicle gets obstructed, food particles inside, long standing sepsis, infection leading on to necrotic tissue, causes inflammation. The moment it breaches this area of the tonsil and gets out of the confines of the tonsil, this is where the superior constrictor lies. This is where the superior constrictor muscle lies. So what happens when infection reaches this area? The patient starts to develop symptoms of Quinsy or peritonsillar. So initially there is inflammation. It is called peritonsillitis. The first stage, earliest stage of Quinsy is called as peritonsillitis. So suppuration has not started, but inflammation has spread to this area. So it's known as peritonsillitis. So in peritonsillitis, the symptom wise everything is going to be the same, but in Quinsy there will be, in addition, accumulation of pus in this space, peritonsillar space, which lies between the superior constrictor and the capsule of the tonsil. So the first theory of Quinsy, how it occurs, happens to be obstruction to the crypta magna. Embryologically speaking, the crypta magna is considered to be a remnant of sinus tonsillaris. So this crypta magna is supposed to be a remnant of sinus tonsillaris, which happens to be a small ventral portion of this first second pharyngeal pouch. So this is actually, this crypt has its origin from the persistent sinus tonsillaris, which happens to be a ventral portion of the second pharyngeal pouch. So this is actually second pharyngeal pouch. So crypta magna, repeat, is a remnant of sinus tonsillaris, which is nothing but ventral portion of the second pharyngeal pouch. So these are the things which you should understand clearly before we proceed any further. And now, curiously, we have started seeing cases of Quinsy in patients who have already undergone tonsillectomy. So that is a real curious thing. So we have seen patients with Quinsy in post-tonsillectomy patients also. In post-tonsillectomy patients. So how we are going to account for it? Quinsy is also seen in post-tonsillectomy patients. How we are going to account for this occurrence? So now this leads to the formation of the theory known as Weber's gland inflammation theory. What are Weber's glands? These are accessory or minor salivary glands. These are minor salivary glands present close to the superior pole of the tonsil and the corresponding area of the soft palate. So these Weber's glands are literally 15 to 20 in number, and they drain their secretions into the surface of the tonsil by ducts. So these Weber's glands play a very important role in clearing up the food material which gets embedded within the tonsillar crypt. So what happens is, secretions from the Weber's gland fill up these tonsillar crypts and help in digesting the entrapped food particles within these tonsillar crypts. So when these Weber's gland get inflamed and get suppurated, what happens is, it forms a swelling in the peritonsillar space. So this could probably be one of the causes for peritonsillar abscess. So obstruction to the duct of the Weber gland are considered to be one of the important factors in as a causative factor for Quinsy. And as I've been telling you, the constrictor muscles of the neck, especially the superior constrictor muscle, is in contact with the suppurated material. So this will have severe pain, spasm of the muscle, neck muscles. So these patients will have excessive pain when this infection has reached the peritonsillar space. So now let us go to the various factors that could cause this problem. So let us go to the etiology. Go to the etiological factors. The first happens to be, we assume the cryptomagna obstruction to be the probable cause. This is the old theory. So probable cause of Quinsy. So we will say etiology could be recurrent attacks of tonsillitis. Recurrent attacks of tonsillitis causing obstruction to the cryptomagna. Then next comes smoking and poor oral hygiene. Smoking and poor oral hygiene can also predispose to Quinsy. And then dental infections can predispose to Quinsy. And now these are all the probable etiological factors. Now how the patient is going to present you, that is known as the clinical features. So clinical features wise, these patients are going to come to you with fever, clinical features, these patients will be febrile, and the next is going to be, they will feel very ill, they will look very ill, and then they will complain of painful swallowing, that is known as odynophagia. Odynophagia is common in these patients because of the spasm involving the superior constrictor muscle when it gets exposed to suppurative material. Since they are unable to swallow even their saliva, particularly in young persons, they start to drool. Saliva will start drooling from the mouth. They will have drooling, and then they will have difficulty in opening their mouth due to muscle spasm. Trismus is seen in these patients. These are all the presenting features. When you ask the patient to talk, they will speak as if they have something in their mouth, that is known as hot potato voice or rhinolalia clausa. Rhinolalia clausa. Rhinolalia clausa is actually also known as hot potato voice. What happens is, the speech of these patients will resemble as if he or she is talking with a hot potato inside their mouth. So that is the typical hot potato voice or rhinolalia clausa, which is seen as a presenting features in these patients. And then on top of it, they will have a foul breath, halitosis, because of poor oral hygiene. They won't have even brushed their teeth because they are unable to open their mouth, and they will have a smelly oral cavity. So halitosis is again commonly seen in these patients. Next, when you embark on your clinical examination, that is on examination, what you will see is this tonsil will be pushed medially, and so what happens is, this tonsil, if this is inflamed, it will be pushed medially, and then this is the soft palate, and there will be edema and inflammation in the soft palate, and then there will be inflammation in the uvula, and the uvula also will be pushed to the opposite side. The tonsil, involved tonsil, will be pushed to the opposite side, and this entire area which I am showing will be swollen, and it will appear reddish in color. This entire area will appear swollen and reddish color. The tonsil in fact will occupy something like this, and then the uvula will be pushed like this. So, and the uvula also will be swollen. The patient will have intense pain. And what happens is, they will have enlarged jugular digastric node. Enlarged JD node. This node is also known as Wood's node. So these patients will have enlarged Wood's node in the ipsilateral side, and this is actually the presenting feature of the patient. The tongue may also be coated because of the poor oral hygiene. Tongue may appear coated because of the poor oral hygiene. Now, let us go ahead and investigate these patients. What are the investigations you will order? One is going to be complete blood count. That's a basic investigation you are supposed to do. And then you need to rule out certain differential diagnosis in these patients. Some other conditions which could mimic Quinsy, you need to rule out those conditions. For that to happen, you need to know the differential diagnosis. So what are all the conditions that could mimic your Quinsy? It is going to be, it can be dental infection or dental sepsis, can mimic Quinsy, and then epiglottitis, inflammation of epiglottis. Epiglottitis can mimic Quinsy, and then Epstein-Barr virus infection. Epstein-Barr virus infection can mimic Quinsy, and then retropharyngeal abscess can mimic Quinsy. So your basic aim of investigating your patient is to rule out these differential diagnoses and to arrive at the correct diagnosis of Quinsy. So we do a complete blood count, and then you need to do the heterophil antibody test. This is to rule out Epstein-Barr virus. Epstein-Barr virus infection can be ruled out if you do the heterophil antibody test. Then, if the patient is having systemic, you need to do blood culture also. Then, ideally speaking, you should send the pus for culture and sensitivity in order to give appropriate adequate antibiotic dose while you manage these patients. So, now how are you going to manage? So, management wise, you can medically manage a patient starting with prescription of broad spectrum penicillin. Broad spectrum penicillin. Which can be ampicillin, amoxicillin. They can be administered parenterally, ideally speaking, because you need to administer them intravenously because the patient may not be able to swallow the drug. You can administer antipyretics if the patient is having fever. Maybe antipyretics ideally is paracetamol. You can administer anti-inflammatory drug like ibuprofen. So you can alleviate the patient's pain by administering ibuprofen and paracetamol in combination. So this will manage infection to some extent, but whenever there is suppuration, there is a great amount of chance of gram-negative as well as anaerobes present in the secretions is present in the pus causing the inflammation. So in that case, you need to administer metrogel or metronidazole. Ideally IV, or you can administer clindamycin again in intravenous as intravenous injection. So this is how broadly you can manage these patients medically. But what happens is that you need to differentiate peritonsillitis from peritonsillar abscess. As I have been telling you, peritonsillitis is the earlier stage than peritonsillar abscess. So you need to differentiate peritonsillitis from peritonsillar abscess. So in peritonsillitis, even if you do IND, there may not be any pus coming out of it because it's the earlier stage then Quinsy or peritonsillar abscess. In peritonsillar abscess, the moment you put the Quinsy forceps inside that area, definitely pus will start streaming. So how are you going to differentiate a person with peritonsillitis from the person with peritonsillar abscess? This is where the unit currently they have started doing this investigation, ultrasound of the oral cavity. So ultrasound of the oral cavity, ultrasound of oral cavity. It will differentiate peritonsillitis from Quinsy. It will also let you know whether the abscess has spread to the retropharyngeal space or parapharyngeal space. So when you do a ultrasound of the oral cavity, it will differentiate, help you to differentiate peritonsillitis from that of Quinsy, and it will also let you know whether the infection has spread to the retropharyngeal space or parapharyngeal space. And then if you are still doubtful, you can go ahead and do a advanced imaging like CT scan. CT scan will clearly delineate the extent, location. It will tell you the extent, it will tell you the location, it will even give you approximate volume of pus. So all these three things can be ascertained if you subject the patient to CT scan of the neck. You should subject the patient to CT scan of the neck. It will give you all these vital inputs. Now, any pus should be drained. So that is a dictum. So how are you going to drain the pus? Surgery is, managing the surgery is IND, incision and drainage. You use a unique forceps known as Quinsy forceps. It is also known as St. Clair Thompson Quinsy forceps. This forceps actually has a very sharp tip, and then you would have seen all the surgical instruments. You would have handled the scissor, or you would have handled forceps. What happens is when you close these instruments, it will act, whereas the Quinsy forceps will act when it is opened. That is the difference between a Quinsy forceps and other forceps. So what happens is your Quinsy forceps will open when you close your fingers. Open when you close your fingers over the forceps. So you hold the Quinsy forceps between your index finger and your thumb. Then the moment you bring your fingers close to each other, the forceps will open. Thereby you can plunge this Quinsy forceps, which has a sharp, roughly about 1.5 to 2 millimeter tip. It will be only 1.5 to 2 millimeter. The sharp tip will be around 1.5 to 2 millimeter. You just insert that forceps and then you close the forceps with your finger. The moment you close the forceps with your finger, the tip will open up. When the tip open, it will widen the area of incision, thereby draining the pus from that area. So where exactly you are going to give the incision? Ideally speaking, is the most prominent portion of the swelling. Ideally you can give the incision in the most prominent portion of the swelling. Otherwise there is another way. So assuming this is the tonsil, this is the uvula, this is the other side tonsil. So now this is the Quinsy. Now you draw imaginary line, a vertical line along the anterior pillar, and then a horizontal line along the base of the uvula. So here at the junction of these two lines, in this area, you give the incision. So you draw imaginary line along the base of the uvula, then drop a vertical line at the level of the anterior pillar. At the junction of these two lines, you give the incision, and then pus will start to drain. So there are two ways of identifying the exact location of Quinsy drainage points. That is, you can just put the St. Clair Thompson Quinsy forceps into the most prominent portion of the swelling, insert it, and then dilate it by bringing your index finger and the thumb, which is holding the forceps, close together, so that the tip will open and the drainage will start. Or you can draw two imaginary lines, a horizontal line at the level of the base of the uvula, and drop a vertical line at the level of the anterior pillar of the tonsil. So at the junction of these two lines, at the intersection of these two lines, you put in the forceps so that the drainage can be performed. So Quinsy again has a potency to cause complications. So what complications can it cause? Complications of Quinsy. Quinsy can cause parapharyngeal abscess. Can cause parapharyngeal abscess. As I have told you, it can cause retropharyngeal abscess. Then it can cause laryngeal edema by involving the larynx. Then it can cause airway compromise, causing stridor, and then it can cause pneumonia when it gets aspirated. Can cause pneumonia. Then it can cause lung abscess very rarely. So these are all the potential complications of Quinsy. The first complication is that abscess can extend into the parapharyngeal space, causing parapharyngeal abscess. Then it can extend to the retropharyngeal space, causing retropharyngeal abscess. It can extend lower down into the larynx, causing laryngeal edema, thereby compromising the airway, causing the patient to have breathing problems like stridor. And then the patient may land up with pneumonia. And last but not the least, the patient may have lung abscess. Now, this is as far as Quinsy is concerned. Hope you had a clear-cut understanding after listening to me. I will advise you to divide the entire topic into different subheadings, small subheadings. As I have told you, I briefly told you the various subheadings as far as Quinsy is concerned. You can use the same technique for all the topics so that you can read, you can assimilate, you can hold these subjects in your memory and then recall when it is needed. So the beauty of reading is breaking down information into various subheadings so that you will be able to recollect these held material inside your brain at the appropriate time, namely during your examination. Thank you very much for your patient listening.